Hello, everybody. This is, can you believe it, the last lecture, first of all, the good news. We're going to cover chapter 10, which is the chapter on adult language disorders, and that includes language disorders, i.e. aphasia, and also cognitive linguistic deficits. So we'll go through them. There are 40 slides, and I'll share them in just a moment. I'm not sure if that is going to go much over an hour. If it looks like it's going to be much over an hour, I will cut it into two, but it will all be in the same week. But I've just gotten into the habit of doing it for myself as well as for you. Of course, you can go through them any way you want to. But let me go ahead and share a screen. Here we go. The slides should be available to you. And I'm going to make this big. So there we are, adult disorders of language, that they refer to it as. And the disorders that we're going to cover are language disorders, and that would be the aphasias. Some people just call it aphasia. Some people refer to it as the aphasias because there are, in some people's conceptualization of aphasia, different categories of aphasia, and we'll get into those. Then there are there's the minor hemisphere syndrome. Oftentimes I lazily refer to it as right hemisphere syndrome because in 90% of the population, at least, the right hemisphere is the minor hemisphere. And by minor hemisphere, we mean it's the hemisphere that does not process language. It's not primarily the language hemisphere anyway. And you'll notice that I have focal etiologies for both of those two categories. That means that the etiologies of them are focal. They're not broad and diffuse over the whole brain, but they're in specific locations. And I think you know a lot about the specific locations already, especially for the aphasias from chapter 2, was it, or maybe 3? Then the cognitive linguistic impairments, we break it down a little bit. And they are qualitatively different in some ways. Cognitive linguistic impairments in traumatic brain injury, cognitive linguistic impairments in dementia, and cognitive linguistic impairments in delirium or confusion. Well, let me just overview the difference between the two. Traumatic brain injury is from trauma and typically would start bad and get better, hopefully. Dementia, I didn't mean to skip that. Dementia is usually progressive, or at least, it's progressive. It doesn't start bad and get better. It usually gets worse. Depends upon exactly what the etiology is, and we'll get into the etiology. And etiology, by the way, means cause. And then delirium or confusion is another form of cognitive linguistic impairment, which is also non-focal or diffuse in terms of the damage that causes it. And I put also dysfunction. Sometimes there is no damage, but there's just the brain isn't working right, but it will when things get adjusted. And you'll see why when we get there. And that hopefully in most diagnoses can be resolved and improved once the underlying situation is improved. All right, we'll get to all of those details, but that's the overview. Okay, so now we're going to take a look at the etiologies, and starting with the focal etiologies. The most common etiology that would be focal in nature would be strokes. We refer to them often in it's more kind of a medical terminology, but you've heard it before, cerebrovascular accidents, or CVA. Basically, that does mean stroke. It's the most common one, and it can be divided into these following categories. The main two categories would be ischemic strokes and hemorrhagic strokes. Hemorrhagic strokes involve the breaking of a blood vessel and the leaking of blood into the brain tissue. And that is about 13% of all strokes. Ischemic strokes involve the deprivation of blood because a vessel someplace is blocked, at least partially, to the point where the neurons, the brain, is not getting sufficient oxygen to maintain its vitality. And you may wonder, how long would that take? How long could you have a blockage? Maybe 7 minutes. It's about roughly how long you've heard that if somebody's underwater for 7 minutes or more, typically they are not going to survive that. But if it's a couple minutes, they very often would. That's really telling us that the brain cannot survive more than 7 minutes without oxygen. And that would be involving, if in a drowning situation, but also if just one vessel is blocked and deprives part of the brain of blood for a period of time, of several minutes, that can involve brain damage too, but it's going to be focal in nature. All right, now, this is very specific. 13% and 87%, it breaks down into hemorrhagic strokes and ischemic strokes. Why so specific? The reason for that is that hemorrhagic strokes are very easy to diagnose. As soon as somebody gets to a hospital, basically, they're going to do a CT scan. You know what that is from one of your early chapters, and it will show the collection of blood right away. Ischemic strokes, on the other hand, do not show up on a CT scan right away. It takes a while, usually a couple days, for the brain tissue to start breaking down and changing its characteristics on as far as how they look on a CT scan, so that the stroke area can be visualized. Up until that point, it really can't, because the brain, even though the neurons are not functioning, they are still there, and they're taking up the same space, and they just appear the same. So that's the reason for the very specific number, 13% versus 87%. Sorry for jumping around like that. Now, when we get into these two, these are both different types of ischemic strokes. One of them caused by atherothrombosis, or just sometimes just called thrombosis, and the other by embolism. And you kind of know something about this, because I know you've heard about embolic strokes, because we studied the circulation of the blood through the heart and everything so in such great detail. Embolic strokes are caused almost always by atrial fibrillation, and they form in the left atrium, go to the left ventricle, out to the body someplace. If they go to the brain, that's going to result in an embolic stroke. So that's one manifestation. A thrombotic stroke, on the other hand, involves the deprivation of blood supply to an area in a little different way. In thrombosis, there is a disease process that takes many, many years to develop, and involves the gradual narrowing of major blood vessels, very often in the neck, the common carotid, or the internal carotid. And one of the favorite locations for that to form is right there at the bifurcation of the common carotid. And there will start to be a buildup of what we could call plaque, which narrows the lumen, the inside circumference of the vessel, to the point where not enough blood is getting through, and you end up with ischemia, which is the condition involving deprivation of blood supply, and finally a completed stroke if that deprivation goes on very long. Now, why the diversity in numbers here? These are a little bit harder to differentiate. Basically, if somebody does not have atrial fibrillation, they will search for a place in the neck, typically, where there is a narrowing, and if they find one, they will diagnose it as a thrombotic infarct. But in reality, sometimes people have the disease process going on, and what happens is the clot that is forming breaks off and flows with the blood, just like a cardioembolism, and that really would result in a thrombotic infarct. But it'll be diagnosed as it'll result in an embolic infarct, I meant to say, but it'll be diagnosed as a thrombotic infarct. So that's a little bit of a confusing point, and the confusion is reflected here in these numbers. Depending exactly how they specify that the diagnosis was made, you'll get different numbers. But the clear number is 13% hemorrhages, 87% ischemic strokes, and then it breaks down as I've tried to show there. We can discuss that more in class. Then brain tumors can cause focal etiologies. They can, by the way, also cause more diffuse dysfunction minimally by putting pressure in all directions. But oftentimes they start regionally and there is no particular pressure and you get a focal signs, like a hemiparesis or whatever it might be. There can also be focal traumatic brain injury, such as in a gunshot wound. You can have, any of the things that you've studied, a hemiparesis, a hemianopia, depends where the brain, where the gunshot wound is. But in something like that, there's often a very good chance that in addition to the focal damage, there is diffuse damage caused by the shock to the brain of a bullet going through it. It's not just going to penetrate perfectly cleanly and not do anything else to the rest of the brain. It's a little more traumatic than that. And then there is a brain abscess, which is an infection, and there are different kinds of infection that can cause a very focal damage to the brain. And those are somewhat unusual. I think in my career, I only saw one person who was in rehab as a result of a brain abscess. He looked just like somebody who had had a stroke. In other words, he had focal damages, he had focal impairments, I should say, as a result of focal brain damage. And that included aphasia in his case, and he had a right hemiparesis. And the cause was a brain abscess, which started from herpes. So herpes can get into the brain, not very often, fortunately, and cause an abscess, as can other types of infections. All right, now we're going to go through each of our main categories of language and cognitive impairments, cognitive linguistic impairments, or cognitive communicative impairments. And we're going to start with aphasia. Aphasia, here it is this is the definition, is an impairment of language caused by brain injury, not caused by any of the following: sensation, for example, deafness; perception; movement, arousal or attention; or memory or other higher mental functions. So in aphasia, somebody demonstrates that they have difficulty processing language in all modalities. It doesn't matter if they're reading it, if they're trying to write it, if they're trying to speak it, if they're trying to understand it, as you might, for example, give them commands, they have difficulty. And you can usually describe that very objectively on some sort of a continuum from very severe to very mild. But in each case, you can rule out that it's not caused by deafness, it's not caused by blindness. In other words, their auditory comprehension deficit is not caused by deafness. Their reading comprehension deficit is not caused by blindness, nor is it caused by perception, which is at a processing at a higher level, but still not involving meaning. Just let me give you a quick idea about how you would identify or how you would determine that somebody's reading comprehension deficit is not due to a visual perceptual deficit. What you could do is have them match words, printed words. Give them a field of 3 different printed words, give them a card with one of those on it and have them match it. And if they can do it, it means that their written word comprehension deficit is not due to the fact that they cannot properly and accurately perceive the written word. Movement. By movement, we mean it's not, if they are impaired in their writing, it's not because they can't move their upper extremity. If they're impaired in their speaking, it's not because they have a paralysis of the speaking structures. It's not due to arousal or attention deficits. And so you can see that they're attending and they're fully alert. And you could demonstrate that, for example, let us say that they are unable to point to objects in a field of 10 when you say the name. That would be a simple auditory comprehension test. But you can demonstrate in the aphasic individual that they can point to objects in a field of 10 imitatively. In other words, you kind of show them that what you want them to do is to point to what you're pointing to after you're done. So you can even do hand over hand cueing for 1 or 2 trials to give them the idea of what we're trying to do. I point to one, I relax, they point to the same one. What are they showing? That they have the attention ability to do our auditory comprehension task, but they can't do the auditory comprehension task accurately. Why? Because they have aphasia. You see, so we're systematically ruling out sensation problems, perceptual problems, movement problems, or arousal and attention problems. And the other thing is memory or other higher mental functions. And you can rule that out too. I'm not going to go into it right now, how to do it, but it's pretty simple actually. We can talk about it in class. Okay, now the general concepts of aphasia are twofold. There is a holistic concept that recognizes just a single aphasia, and the differences from one individual to the next, and there are very significant differences, has to do more with the severity of the aphasia and also any accompanying impairments. And the very common accompanying impairment would be apraxia of speech. So people who hold a holistic concept of aphasia would recognize aphasia along a severity continuum and either with or without apraxia. Those with apraxia are non-fluent. Those without apraxia are fluent, and they'll manifest their language problems in other ways. And also dysarthria could be a complication. So the way individuals may be differentiated and even appear to be in different categories would be on the basis of severity of the single aphasia and the accompanying disorders. On the other hand, the localizationist approach recognizes qualitatively different types of aphasia that differ in location of a brain injury. And you remember Broca and Wernicke. Those were the neurologists that first identified those particular 2 types of aphasia, and they appeared to be qualitatively different. And then over the years to follow, other people started identifying other categories of aphasia that appeared to be qualitatively different, and that there are about 6 or 7 of them. We'll go through them. And so those individuals believe that they are qualitatively different types of aphasia and that they are associated with different areas of brain injury, whereas the holistic view is that there's a single type of aphasia and it varies in severity. And there's a lot of research on this, starting mostly in the 70s, because up until the 70s, and that would be the 1970s, by the way, mostly until the 70s, the localizationist approach was the common one coming out of the field of neurology. And then once SLPs, who didn't, 100 years ago, there weren't any SLPs, but in the 40s and 50s, SLPs began to emerge in a profession, and many of them studied language a lot and felt that the holistic better explained differences among individuals. All right, so now looking at the localizationist concept, these are the types of aphasia: Broca's and Wernicke's, which you're familiar with, anomic, global, transcortical motor, and transcortical sensory, and then conduction. And we will go through each one of those and give the characteristics and also the area of the brain that is damaged. All right, so now here's a nice little slide that comes from the chapter. And I was not able to get the table from your chapter to download properly. This is from an earlier version of the book, but it is precisely the same table, except for one thing. Here it says table 11.1, and in your book, it is table 10.1. As you look at the information, it's all the same. So this is a very convenient little table that shows the pattern of differences. And let's start with the first one, Broca's. And you'll see that the first characteristic has to do with spontaneous speech, and it's categorized as non-fluent. And then as you look down here, you'll see fluent, mute, and the worst kind of aphasia. They essentially can't speak. They may make some sounds, but they're nearly mute or completely mute. And then anomic, also they could be referred to as fluent, and they are, but they have difficulty with word recall. And then non-fluent, fluent, non-fluent. So we'll go through each of these, but I just wanted to show this basic dichotomy between non-fluent and fluent as a very important factor that goes into typing the different types of aphasia. And then auditory comprehension. Now, they're just sort of dividing them into pretty intact and not intact. So that's what the source of the plus and minus. And we'll take a quick look at the test by which you can objectively make these determinations. Then repetition of speech, or we could refer to it as imitation of speech. And then reading and writing, I'm not going to pay much attention to at this point. I'm just going to refer to spontaneous speech comprehension, which is, by the way, auditory comprehension, repetition or imitation, and then reading and writing, we're going to kind of leave off for the time being. Essentially, in summary, I could say about reading and writing that overwhelmingly, reading and writing deficits are proportional to deficits in auditory language. Forget about speaking, because that can be very contaminated by the presence of apraxia speech, resulting in non-fluency. But if you just look at this as the main indicator of the severity of aphasia, some kind of a measure of auditory comprehension of language, reading and writing parallel it quite well. There are educational differences. If somebody has been highly literate and highly educated, their reading and writing will tend to be better than the person who was maybe had a third grade education, which makes sense, of course. These functions are not as practiced in that individual, most likely, and so they'll tend to drop off more severely in response to brain injury. All right, so this is a table that we'll refer to again as we're working out problems in and describing the different types of aphasia, but it's a nice little summary. And you'll see it correlates quite well with the slides that follow that describe the patterns of deficits in the different types of aphasia. Okay, so let's look first at the fluent aphasia. So that would be all of these that were marked as fluent. Okay, what are they? Well, going down to the end point here, jumping ahead to the end, they are anomic aphasia, Wernicke's aphasia, transcortical sensory, and conduction. They're all considered to be fluent types. All of them have some degree of deficits across all four modalities of communication. You won't find anyone who has 100% perfect auditory comprehension, for example, or perfect reading comprehension. It could be pretty close, but not what it was before their illness. They have fluent, well-articulated speech. Now, by well-articulated, I mean it sounds normal, but it could be completely unintelligible. But it sounds as if, you're just listening to somebody and you think, well, I'm not sure what language they speak, but they sure speak it well. That's how it can sound, that it's not intelligible, but it sounds normal. It has the sound of normalcy. That would be, for example, a Wernicke's aphasia. And we'll look at the details of that in a moment. Okay, so it's fluent and well-articulated speech in the fluent aphasias. They may have semantic and literal paraphasias. Paraphasias are basically substitutions. It can be a sound substitution, and that would be a literal or phonemic paraphasia, or it could be a word substitution. In other words, it's a real word that's being expressed, but it's the wrong real word. That would be referred to as a semantic or verbal paraphasias. In other words, semantic and verbal paraphasias are the same. Literal and phonemic paraphasias are the same. Okay. If you get the most extreme version of this paraphasias, you can't understand it, and that's referred to as jargon. And it's found in severe aphasia, but only in the fluent aphasia. So that would be found in Wernicke's aphasia or also transcortical sensory. And what it is it's fluent, differentiated, I'll say more about that in a moment, unintelligible speech that sounds like a normal foreign language, like the example I gave. What do I mean by differentiated? There's some people and they're always very, very severe aphasics. And we indicate, and I mean that they would have very poor auditory comprehension, plus they don't express themselves meaningfully and well. But they can have undifferentiated jargon that is fluent. A very typical example would be somebody who just says D. So you say, how you doing today? D-D-D-D-D. See, I'm doing it fluently, but it's undifferentiated. I only have one syllable and I have a melodic line. What do you think about this? D-D-D-D-D-D. That's undifferentiated jargon. That's not what we're talking about. That's not referred to as jargon. That's undifferentiated speech. But the true meaning of the word jargon is fluent, differentiated, unintelligible speech that sounds like a normal foreign language. Okay, now what are the fluent types of aphasia? Anomic, which is a very mild form. It can be pretty disabling, but it is, as aphasias go, a very mild one. Wernicke's, which is quite severe. Transcortical sensory, which is severe but with a preserved ability to imitate speech. And conduction aphasia, which is a fluent aphasia with relatively preserved auditory comprehension and poor ability to imitate speech. We'll go through each one of those. Let me look first at the non-fluent aphasias. We looked at the fluents. In the non-fluent aphasias, again, the same thing. There's some degree of deficit across all four modalities of language. What are the four modalities of language? Auditory comprehension of language, verbal expression of language, reading comprehension of language, and written expression of language. In the non-fluent aphasias, speech pattern is characterized by halting, non-fluent prosody. In the most severe cases, speech may be absent. There's visible and awkward groping for articulatory error, variable articulatory distortions, additions, omissions, and substitutions, and an agrammatic pattern of speech. Those who can speak, and some cannot, those who can speak will show reduction in grammar. They just don't have the inflectional endings in words. They don't have prepositions. They'll tend to be sort of telegraphic, where they may, if they're functional at all, they may have the noun and the verb in a sentence, or the noun, the verb, and the object, but none of the filler words that give additional meaning. The non-fluent aphasias include Broca's aphasia, global aphasia, and transcortical motor aphasia. In transcortical motor aphasia, they look just like a Broca's. They're non-fluent. They have relatively preserved auditory comprehension, and they can imitate speech much better than they produce it spontaneously. Okay, let's look at cerebral localization of each of them. So here are the ones we're going to look at: Broca's, Wernicke's, anomic, transcortical motor, transcortical sensory, global, and conduction. And this is a familiar illustration to you, I think, from one of the chapters. So first, Broca's aphasia, and you already know this. You know it from chapter 2, I think it was. Broca's aphasia is associated with brain injury that includes Brodmann's area 44 and 45, or the third convolution right here, and that would be on the dominant side of the hemisphere. Wernicke's aphasia, you already know this one. The damage is in the Wernicke's area, which is the posterior portion of the superior temporal gyrus, or Brodmann's area 21 and 22, basically, posterior port of 22, because 22 goes all the way down here, and a little bit of 21, a little bit of 21. I'm going to stop sharing for just one moment and come back. All right, sorry about that little interruption. Okay, let me make sure. Yeah, so we did Wernicke's. Now we're moving on to anomic. And in anomic aphasia, first of all, the lesion is going to be small. It is the least reliably localized according of the aphasia syndromes, according to research by Goodglass and Kaplan, who are very involved in localizationist type research. It is in the temporal parietal region. Typically, it wouldn't be in the frontal region, where you might get some more kind of disfluency and apractic type of characteristics. It may involve the angular gyrus, and that is the orange area in the image I'm going to get by clicking on this. Let me show you this. And here we get our image. So back here, right back here. And you can see basically it's sort of, here's our language region, the anterior and the posterior language region. And this is just a little bit out of it. It's close, but just a little bit out of it. So I will stop sharing. I'll stop sharing that and come back. Okay, yeah. So the angular gyrus, and it does suggest the least amount of involvement in the area spanning Broca's to Wernicke's, which is the area I pointed out. So what's its chief characteristic? We'll look more at the characteristics. We're right now just looking at the localizationists, but it's the least severe of them. Can be very debilitating if you have real trouble with thinking of words to express yourself. It can be quite a problem. Transcortical sensory aphasia. In transcortical sensory aphasia, the area is just outside Broca's and Wernicke's area. And basically there's a disconnection between the language zone, which you know is here, and the rest of the brain. It may include areas 37, let's find it, 37, 22, and 39. So right around here. It's sometimes referred to as a watershed lesion, which means near the periphery of the distribution of the MCA, out where the smaller branches are located. So where the big branches, here. As you go out further and further, you get into smaller and smaller branches, and those are called, those strokes in those areas can be called a watershed lesion. And the characteristic of it is that they do have language involvement, but they express themselves fluently, and they can repeat, they can imitate speech better than they can comprehend speech, which seems kind of odd, doesn't it? That you can imitate things that you can't comprehend, but that is the characteristic of the transcortical sensory aphasias. Transcortical motor, they have preserved imitation ability too. But in their case, the lesion is superior to and or anterior to Broca's area. And they may this lesion may disconnect Broca's area from the basal ganglia and from the thalamus, affecting the deep white matter in the region of Broca's, but deep to it. And let's look at the image. Okay, and out here. So here's Broca's area. So deep to Broca's area or out here may result in transcortical motor. All right. Back here. All right. Global aphasia. It's sort of awkward to go back to that image, but it's the same one. And in global aphasia, it's the anterior and the posterior language areas and everything in between. Basically, it's a large lesion covering the much of the region that receives blood from the MCA, and it does include Broca's and Wernicke's and everything in between. Conduction aphasia involves the arcuate fasciculus. Remember the connection, the band of white matter connecting the anterior and the posterior areas, connecting Broca's and Wernicke's, located just deep to the supramarginal gyrus. I will look at that supramarginal gyrus here. Here's the supramarginal gyrus. So deep to that, you'll find the arcuate fasciculus connecting this and this. And deep to that, a lesion can result in this relatively fluent speech, relatively preserved ability to understand spoken language, but an impairment in imitating speech. Seems odd, doesn't it? I've never been very impressed by the clarity of that pattern, but anyway, that's me. And I have lost my mouse here temporarily. Okay, let's go back here. Share that screen again. And there's our conduction aphasia. All right, now the types of aphasia can be determined in various ways, first of all. So it's not simply dependent on this one test, but the most commonly used test, and there's one other that I don't have on a slide, but I'll just state it. The most commonly used test is the Boston Diagnostic Aphasia Exam, which first of all is a very comprehensive language exam. It assesses objectively all 4 modalities of language comprehension and expression. So that would be verbal expression, auditory comprehension, reading comprehension, and written expression. Those are the 4 modalities. So it assesses them in great detail. Actually, it's a really nice test. But in addition to just objectively assessing language in those 4 modalities, it's designed to be able to identify the pattern of the language deficit so as to assign the individual to one of the diagnostic categories that we just went through. And in addition to the objective language testing that's done, this is basically what they're looking at in terms of the information that's needed to assign a patient to a category, and that is fluency. Remember that table? Non-fluent or fluent. Yeah, everybody ends up into a non-fluent or fluent category. Here's how they do it. They look at phrase length, and I'll define that when we look at the test in just a moment. Melodic line, articulatory agility, and grammatical form. And then they also look at word finding in a subjective way that I will show in a moment. They look at whether they're paraphasias, literal or semantic. And then they look at test scores for sentence imitation. So that would give your ability to imitate. Remember the table, refer back to the table, that was important. And auditory comprehension, and that was important too. That's based on test scores for that. But these other things are based on a subjective analysis of their spoken language pattern. And I'm going to go ahead and click on the test. You may want to spend a little bit of time with it, but I'm going to go directly to page 8. So it's the Boston Diagnostic Aphasia Exam, written in, I believe, 72 by Harold Goodglass and Edith Kaplan at Boston University. They're very well known. They were both psychologists, I believe, not SLPs. Okay, so here's page 8. Oh, here's what I wanted to look at. So those first, there's those first things: articulatory agility, phrase length, grammatical form, and melodic line. So note that they are using a 7-point rating scale. And again, that's this part of the Boston Diagnostic Aphasia Exam is not a test. It's a set of rating scales used to describe their pattern of communication just simply by conversing with them. In other words, you're not testing them, you're just conversing with them and seeing the quality of their conversational speech. And articulatory agility is on a 7-point scale, ranging from unable to form speech sounds at all. And so you're looking at the phonemic and the syllabic level. Here we see phonemic and syllabic level. Sometimes clumsy and effortful, right in the middle, 4. And 7, never impaired. Those would be the people who maybe aren't expressing themselves well at all, but they have that normal sound you might think is a foreign language. Phrase length. You're measuring the longest occasional uninterrupted run of words. Can range from 1 word, and for people who are mute, they're going to get the 1, to 7 words, which would be, pretty much full sentences with connected lines of speech that you would say, well, that's 1 phrase, and I heard 7 words. So that's occasional, and I think they define that as 10%. So if you were to analyze every utterance and say how many words were in that phrase that was uninterrupted, and write the number down, and then take the highest 10%, and that would be 7 in somebody who's judged to have normal phrase length. Keep in mind that all of us speak with one-word utterances sometimes too, so that's why they're looking at the longest 10%. Grammatical form, ranging from no syntactic word groupings. That would be somebody who might actually be sort of meaningful by speaking with nouns and verbs, but no inflectional endings, no tenses, no prepositions. They could be down here. Somebody who's very simple, is very simple in their grammar here, and then normal range of grammar. And then melodic line, where you at one end, word by word, or aprosodic speech. That means speech without prosody or connection. Sentence intonation is normal only in short phrases at the 4 level, and normal speech melody. And that's again, it's an impressionistic thing. You're not really testing, of course. You're just listening to their pattern of speech and measuring. So now these 4 things, people tend to cluster. Those who are cluster at 4 and below are going to be assigned to one of the non-fluent categories. Which category? Well, you have to study, you have to test their auditory comprehension, and you have to test their imitation skills. So all you can do with these 4 is say, okay, they're going to be one of the non-fluent, versus people who are 5 and above. And they do tend to cluster like that. Of course, you get some people who cross a boundary. You know, they're not clearly in a non-fluent or a fluent category, but it's pretty good. I mean, it's pretty easy to assign most people. What percent? I don't know. I can't say. I would say probably 80% are pretty clearly assignable to a fluent or to a non-fluent, and the other 20% are kind of too close to the middle ground. Now, paraphases. They're either present in every utterance at one end, or you never hear paraphases. That could even be, now the anomic aphasic may have trouble finding words, but never substitute them. They'll say something like, I'm looking for that, oh, what do you call it? You know, I'm having trouble finding the word, but I'm not producing a paraphasia. If I say I'm looking for a pen, but I'm not looking for a pen, I'm looking for a pencil, for example, there's a semantic paraphasia. I did it fluently. I produced it as if I think it's right, but it's not. So you're assessing this in conversational speech again. Literals are very easy to find because they're not real words. Semantic paraphrases are a little trickier because you're sometimes not quite sure if it was their intended meaning or not. But after you listen to a while, you can figure out that they're saying things as if they mean them, but they really don't. They're using the wrong word, in other words. Okay, and then you also in conversational speech assess word finding relative to fluency. And at one end, the Wernicke's, for example, where their comprehension is poor, but their fluency is good. They're fluent, but they have empty speech. They are not communicating their intended meaning. And then on the other end of the continuum would be Broca's, or the non-fluent. Broca's is the best category, transcortical motor also, where their output is primarily content words. That would be like verbs and nouns. But they don't have the inflectional endings, and so they end up over here. Then the simplest thing here on this test, and you could do this, I could teach you to do it by tomorrow, would be to test sentence imitation. They have a bunch of sentences on the Boston Diagnostic Aphasia exam. You say it, and then the patient says it. They're right or wrong, and then you score them, and then you put them on a percentile curve and put the little score down here. Same thing for auditory comprehension. There are several tests, but there are specific 3 tests that are given, and you take the mean of the score and put it on here, again in a percentile. And this gives you your profile. So based upon this profile, you can assign most patients, I'm guessing about 80%, to a category. I think there's been research on what percentage of patients can be assigned using this particular system clearly to one category versus another, but I can't cite that research at the moment. All right, now it'd be a good idea just to look through the rest of the test. I'm not going to test you on it, but just to see what is on an aphasia exam. And you can see it's got auditory comprehension tests ranging from easy at the word level to complex at the spoken paragraph level, where you actually read a paragraph to somebody and then ask them questions about the content of it. And the same thing for reading comprehension, same thing for verbal, from easy to hard. And the thing I like about the Boston, just to give a plus for it, is that it allows you to give some subtests, but not all, and to determine the percentile ranking for the patient relative to other aphasics who are in the normative sample on that particular subtest. So for example, if you figured out that your person was pretty mild in their aphasia and you just want to know how well do they understand complex spoken commands that have 3 parts to them, touch your right ear, your left shoulder, and your chest. There are three parts. And how do they understand spoken paragraphs? How well do they understand spoken paragraphs? I can just give them those 2 subtests and determine their percentile ranking relative to other aphasic persons who are in the normative sample. And I can do that in about 5 minutes, probably. So once you sort of size up your patient, you can quickly, objectively assess their problem areas using the Boston. And that's one of the reasons I really do like it a lot. I'm not such a huge fan of this of the typing part of it, but I do know how to type, and I've typed many. One thing about the types that I like a lot is that it allows you to focus on people who have preserved ability to imitate. Those would be the transcortical sensory aphasics and the transcortical motor aphasics. And the preserved ability to imitate is a very, very good prognostic sign for both of those categories. They both do better than the person who has similar scores on everything else, but they don't imitate as well. That preserved ability to imitate is an excellent prognostic sign. And this focuses you on that, although you can figure it out without using the Boston too. All right, let me stop sharing that screen because I wanted to show that primarily this, so you knew how we go about assigning people to categories of aphasia. And go back to the slides. All right, so I think we covered that, the characteristics of Broca's aphasia. No, we did not cover that. We covered this. So we just overviewed what you look at in order to be able to type aphasias. Now let's go through each one. In Broca's, fluency is relatively impaired. So you might want to refer to that table if you open your book and refer to table, I think it's 10.1. You'll be able to see how I'm translating that basically into words. Word fluency is proportional to fluency. Word finding is proportional to fluency. Meaning if you have no fluency and you can't produce anything, you're not going to have good word finding either. If you have better word finding, which means they could go up to kind of the 4 point on that scale of fluency, they have word finding that's pretty good too. Paraphasias. Now, there's something about paraphasias I didn't mention. Paraphasias technically are only substitutions of sounds or words that are produced fluently. If they're produced in a groping, halting way, they're not referred to really as paraphasias. So Broca's are non-fluent. Therefore, by definition, they tend not to have paraphasias, even though they may have substitutions. And as you see them, are grope for the correct articulatory position, they may hit the wrong one, and they'll tend to distort some of them. Sometimes it'll be a substitution, sometimes it'll be a distortion. They're groping to try to achieve the right articulatory posture for a particular sound, I should say. And they're doing it awkwardly and with groping. And when they hit a sound that is a substitution, you say, oh, there's a literal paraphasia. Not really, because it was done in a groping manner. So paraphasias are produced in fluent speech. Repetition also is proportional to fluency in the Broca's aphasic. That is, if they can't produce any spontaneous speech, they're not going to be able to imitate it either. But if they can produce three-word utterances somewhat, and get up to the 3 point on those first 4 things on the fluency indicators, they can repeat some things too at that level. Auditory comprehension is relatively preserved compared to their other deficits. Characteristics of Wernicke's. Fluency is relatively preserved. It can be really good. It can be, 7-word utterances. They just sound like they're speaking another language, but it's good. Or sometimes they sound like they're speaking their native language, but you think, what are they talking about? It's loaded with semantic paraphasias. They're not really saying what they intend to say. And because of their comprehension deficit, they don't really realize it. What they'll tend to realize is you don't seem to be getting it. And I've seen some, depending on their personality, who will get really angry with you because they said it, but you didn't reply appropriately. Why? Because you couldn't understand what they're talking about. So their fluency is preserved, their word finding is significantly impaired, and that can be reflected in empty speech. It can be reflected and is reflected in the more severe cases in semantic paraphasias that are fluently produced and the patient doesn't seem to recognize it. And they can have literal paraphasias. If it's really, really bad, that's referred to as jargon. And those are the patients that you can't understand, but it has that normal quality to it of a foreign language. The repetition is proportional to their comprehension. Their comprehension is not very good. Their imitation or repetition is not very good. Repetition and imitation I'm using synonymously. And their auditory comprehension is significantly impaired. Again, how do you determine what is significantly impaired? You do it objectively with test results, and that's on that scale. So once you study the Boston Diagnostic Aphasia exam, that part becomes very easy. Repetition and auditory comprehension, easy to put on the scale because you do it objectively with test. Anomic aphasia, again, referring to the table, fluency is relatively preserved. Word finding is impaired. In their paraphasias, typically they don't have literal paraphasias because their auditory comprehension is too good for that. They can hear that, their language is just too good for that. So they don't produce, without knowing it, lots of substitutions of sounds fluently. They may have semantic paraphasias, or they may have obvious word finding failures and delays. Again, I'll give you an example. Would you please hand me that pen, but I really want the pencil? That's a semantic paraphasia. Or would you please hand me that, what is it? Oh, you write with it. That's a word finding failure. It's not a semantic paraphasia. I didn't produce the wrong word. I failed to get the right word. Repetition in anomic aphasia is relatively preserved, and auditory comprehension is relatively preserved. These are 3 examples that I just got from YouTube, and they're very short. I'm not going to take the time to look at them now, but would you look at each one and just keep the table out in front of you to see if you can see it. Now, keep in mind that you're watching a little conversational snippet, so you're not going to be able to see everything on page 8 of that. But I think I think that you can especially see the fluency aspect of it, and probably get an idea about the comprehension too, just by observing them. Okay. And of course, we're going to look at examples in class because we have observations to do. So I will choose some of those, and we'll go into more detail. The characteristics of transcortical sensory. Let me just cut to the chase. First of all, if you go back to Wernicke's, it's the same, except in this group, they have relatively preserved ability to imitate. So breaking it down, just like the Wernicke's aphasic, their fluency is relatively preserved. Their word finding is significantly impaired. They may have both, and probably do have both literal and semantic paraphasias. Why do they have paraphasias, whereas the anomic probably doesn't? Because their comprehension is so bad that they just can't hear that they're saying the wrong thing, basically. It sounds okay to them. Their repetition or imitation is relatively preserved. And again, we determine that objectively with test results. And their comprehension, auditory comprehension, is significantly impaired. Again, we determine that with the test results. Transcortical motor, they're just like Broca's, except they have relatively preserved ability to imitate. So their fluency, like a Broca's, is relatively impaired. Their word finding is proportional to their fluency. Some of them are so severe they have no fluency. They can't demonstrate word finding either. Their paraphasias are not present almost by definition, because these are the people who are groping for their articulatory posture and they're not showing fluency. And therefore, when they make mistakes, we don't classify them as paraphasias. Their repetition is relatively preserved, and their auditory comprehension, just like Broca's, relatively preserved. So what's the difference between Broca's and transcortical motor? Repetition. Who has a better prognosis? Transcortical motor. I love those patients because they do really well. Characteristics of global aphasia. Well, those are the most severe. Their fluency is relatively impaired. They may be mute. Their word finding is significantly impaired. Paraphasias, because this group is non-fluent by definition, any speech that they do produce, which has a substitution of a word or a sound, probably is not going to be classified as a paraphasia because it was produced awkwardly with groping. Their imitation is proportional to their comprehension. Their comprehension is not going to be very good. So that, going to the next point, significantly impaired. How good is their imitation? About the same, not much better. Okay, I put this in there just to familiarize you with the term alexia and agraphia. And the reason it's in there is because your textbook is sort of oriented toward a localizationist approach. And this is part of the localization approach to communication, including people who have alexia and agraphia. This table shows what it is. So agraphia is a disorder of writing caused by cerebral injury, and it tells where the injury where the injury is, or it's supposed to be anyway. So you have agraphia, you have alexia with agraphia, alexia without agraphia, frontal alexia, and aphasic alexia. So you should at least be familiar with what alexia and agraphia are, not so much the localizationist, because it's not that accurate actually. And you won't see many people who have something which is properly labeled with one of these terms. You should only label somebody as agraphic if that's all they got. In other words, they're speaking, they're understanding, they're reading, but they can't write. And it's not because it wouldn't be because of a paralysis. They demonstrate an inability to write, which goes beyond any weaknesses that they have in one extremity. You could have a right hemiparesis and write with the left hand if you have no language disturbance. Probably not as good, but you can do it. So somebody with agraphia can't, in spite of the fact that they could name the object, they can understand commands using the object, etc., but they can't write it. All right. Now let's look at minor hemisphere syndrome. It's the right hemisphere syndrome in most people, but more properly, it's labeled the minor hemisphere syndrome because for accounting for 10% of people who may have switched laterality of their language. It can be caused by any of the etiologies that can cause aphasia. The etiologies that cause aphasia are focal. Well, if the focal lesion is on the other side of the brain, you can have a minor hemispheric syndrome then, but the etiologies can be the same, they just have to be on the other side of the brain. I put here a little reference, and there are many, about handedness and hemispheric language dominance in healthy humans. And so I just thought it might be interesting, but I won't test you on that. Incidence and prognosis as a function of handedness. That's kind of interesting. People who tend toward being ambidextrous would tend to have a better prognosis for recovery of language. And it kind of makes sense because they kind of have something going on a little more on both sides of the brain. Like I said, there's a lot of research in that area. And one of the reasons there's so much is because it can be studied without studying only brain injured people. You can study using electrophysiological measurement techniques, etc. What are the characteristics of a minor hemisphere syndrome, which you will see if you work at rehab? You see a lot of them. Probably half are aphasic and half have a minor hemispheric syndrome, but here's what they have. They do have linguistic deficits, but it's at a different level from that of an aphasic. They have difficulty with auditory comprehension of complex materials, especially comprehension that requires inference. What do I mean by inference? Reading between the lines, something that's not explicitly stated, but that a normal language user would understand. They will have some difficulty with word fluency. And word fluency now it's a technical term. When I say it, I should put it in parentheses. The way it's measured is by giving somebody a category to list words in. For example, the Boston Diagnostic Aphasia Exam has a measure of word fluency. And the way they do it is to say, I want you to name all the animals you can think of in the next minute while I time you. Let's start with lion. Okay, so you're getting them started. And you're simply counting the words. It's not the same thing as their fluency in connected speech. Too bad they use the word fluency, but that is what's being referred to here as word fluency, measured that way, not the fluency of their speech. Because their speech will be fluent, but their word fluency measure will be down. Why? They don't seem to think creatively. So they can get the first one and then they may go off track and go on something else. But if you simply show them objects and say, what's this? What's this? What's this? That's naming, they can do it. But if you ask them to name as many items in a category as possible and as fast as possible, they're not good. Their word fluency is down. Their reading comprehension is usually impaired to some extent. And keep in mind that for complex printed material, they'd have the same thing going on. The more complex it is, the more difficult. And if it requires inference, really difficult for them. But in addition to that, it may be complicated by a left hemianopia. And in people who have a minor hemisphere syndrome, typically, if they have a hemianopia, they also have a left visual field neglect. That's what it's called. It means they have no awareness of things being on the opposite side. If you take an aphasic person who has a right hemianopia and a right hemiparesis and their aphasia, give them a plate of food and say, here, eat your food, they'll eat the whole thing, generally. Even though they have a hemianopia, they have an awareness of the other side of the world, and so they turn their head. The person with a left visual field neglect does not have that awareness. So they will literally eat everything on the right side of their plate up to the midline. There's like a line going right down the plate, and they don't eat to the left of it, indicating they have a neglect of that side of the world. That's the left visual field neglect, and that obviously complicates reading. It also complicates writing. So they will have some difficulty with writing, and especially if they have the left visual field neglect. They also have trouble with extralinguistic deficits. Now, but what do I mean by that? We're not talking about phonology, not talking about grammar, and we're not talking about retrieval of concrete words. We're talking about being literal in interpretations of things, Part of that is not being able to read between the lines. I mean, when I say literal, if you give them figures of speech like a bird in hand is worth two in the bush. Have you ever heard that one? They don't have no idea. They just can't figure it out. If you say, what does that mean? They'll say, well, it means if you have the bird in your hand, it's worth more than two in the bush. They can't see the interpretation of expressions of speech. They have difficulty identifying relevant information. They have difficulty interpreting body language and facial expressions. They don't seem to recognize facial expressions and their implications, like looking anger, looking pleased, etc. Continuing with that same list, they have a flat affect. That means they themselves look kind of emotionless. That is a flat affect. They have problems with conversational rules, the pragmatics of it, initiating conversation, saying things that are contingent to what your speaking partner has said. Like, for example, if I said to a person with a minor hemisphere syndrome, something interesting happened to me today, they very well might not say, well, what? Even though they've got the language to do it, but they don't have that part of the language to do it. They can tend to be impulsive, and they can tend to confabulate, which means make things up in their expressions. And aphasic tends not to confabulate. They don't make things up because they know what's going on. They also do have non-linguistic deficits, including disorientation to time and location. They've got the left side neglect. They may very well have something called anosognosia, which is a lack of awareness of one's own impairment. I remember the first time I saw that was in the Veterans Administration Hospital when I first went to work after my doctorate. We went to these neurology rounds where they would demonstrate the problems in a particular patient. And this was a demonstration of anosognosia. And they brought this gentleman forward in his wheelchair, and he had a right hemisphere stroke with a left side hemipresis. And the neurologist asked him, do you have anything wrong with your body? And he said, no, I'm fine. And he said, what about your left side? Can you move your left side? Yeah, I can move my left side. Can you raise your left arm? Sure, okay. And he said, can you raise it now? And he said, well, I am raising it. But there was no movement. He had a hemiparesis. And finally, after a lot of cueing, the patient took his own left arm like this and raised it. And he said, do you have any problem there? He said, nope, completely unaware of his own impairments. And then they may also have this thing called prosopagnosia. Prosopagnosia, did I spell it right? Yes, I did. Prosopagnosia, which is impaired ability to recognize faces. Earlier, I said some difficulty with facial expressions, but they do have also, if you just give them simple tests of matching identical faces, photographs of people in small fields, they have difficulty with that. Okay. Cognitive linguistic deficits in dementia. In dementia, the etiology, whatever it is, which I've listed them here, is always going to be bilateral and cerebral, not bilateral and brainstem, but bilateral and cerebral. These are the most common etiologies. Multiple strokes. You can have strokes on one side, then the other side, and you end up with dementia. Alzheimer's disease is really the most common one. It's very common. Chronic metabolic disorders, and those would be, for example, thyroid imbalances that are uncorrected. The dementia of chronic dialysis, people who have dialysis because of kidney failure or renal failure, generally are dialyzed 3 times a week. And in between the dialysis, the toxins in their blood go up. And then toxins are not good for the brain. And so they will begin to, be tired and not be as cognitively alert in between. And over a period of years, they can do very well at first, but over a period of years, that begins to take a toll on the pain and on the brain, and they can actually develop dementia from that, chronic up and down. with toxins. Chronic alcohol abuse can produce a dementia. Vitamin deficiency can produce a dementia, or malnutrition can produce a dementia. But overwhelmingly, the most common ones are multiple strokes and Alzheimer's disease. You'll see a lot. Well, if you work in rehab, you won't, because these patients don't get admitted to acute rehab, but they do get admitted to hospitals for a variety of reasons, including another stroke or a new onset of pneumonia. And you see people, and then you look at their history and you see, okay, Alzheimer's disease or a history of multiple strokes. Okay. Okay, I skipped this slide. So we're going from the etiology to the characteristics of dementia. Memory loss would be a hallmark. And in terms of memory loss, which is such an important area, there are three areas of memory. Long-term memory, which is where you house your long-term information, such as your name, your date of birth, your address, unless you just moved, is probably in your long-term memory. General information like, who is the first president of the United States? If you took your history here, in the US, then you ought to know that. It's in your long-term memory. Short-term memory is your memory for a specific amount of information for a very brief period of a few seconds or a minute or so, when it's uninterrupted. And the way it's tested is with digit span. You say these digits back to me. 4, 7, 2. 4, 7, 2. Okay, so I have a span of at least 3. Okay, now say these digits back to me, and I'll keep going until I get up to 7. And 7 plus or minus 2 is considered to be normal. So the normal person can repeat digits said just like I was saying it, slowly and one digit per second. They can do 5 to 9. And any place in there you think, okay, their short-term or immediate memory is good. Then recent memory is kind of a short term, but for longer, and it can survive interruption. So for example, if I just ask you, what do you have for breakfast? I bet you know. It's in your recent memory. It's survived the interruptions of everything you've done since breakfast, but you still remember it. If I say, what did you have for breakfast on, November 21, 2015? You don't know. And it's not there either. Probably, most likely it's not there unless there's something very memorable about it. It was in your recent memory, but now it's not. So you see, it's not the same as long-term memory. And the point I'm going to get to here is that recent memory is the most sensitive memory to brain injury. And so the first thing to go in dementia is recent memory. People who have a very mild Alzheimer's disease cannot do the following test very well. Even when they can do a normal digit span, 5 plus or minus 2, they can do that still. They can tell you their name, they can tell you their address, their long-term memory is intact. Here's the one that's very sensitive for a very mild dementia. I'm going to give you 3 words. The words are wagon, robin, and blue. Do you know what they are? What are they? They say wagon, robin, blue. We're just demonstrating that they have a short-term memory with at least a 3 span. And then you say, I want you to remember those because I'm going to come back and ask you what they are again later. And then you do some other testing, whatever it is, you go do your other testing, and then you come back later and you say, hey, remember those 3 words? What were they? Well, of course, everybody here in this group could say wagon, robin, and blue, but that's the part of memory that's very sensitive and will break down. Even in somebody who seems pretty functional, you may not notice anything, but there may be some suspicion. That simple little test is very telling. So memory loss, first recent memory, then short-term memory, and then long-term memory. It goes like that. Language problems, but only when dementia is more severe. Inability to learn or remember new information. Well, that's a kind of a reflection of memory. Difficulty with planning and organizing things. Difficulty with coordination and motor functions, but only when it's more severe. Personality changes, again, when it's more severe. Inability to reason, changes in behavior when it's more severe, apathy or loss of interest in activities, and even paranoia. So starts out with very, very subtle memory difficulty that might be reported by the family or the patient and is testable and identifiable. And progresses to include all those other things. Cognitive impairment, cognitive linguistic or cognitive communicative impairment in acute confusional states. Acute confusional state is also referred to as delirium. And I thought it would be a good idea for you to know about these, because if you work in an acute hospital setting where people are newly admitted for new diagnoses, you will see people who have acute confusional states. It always involves bilateral cerebral dysfunction, if not damage. Maybe not damage, because they can be completely reversible. And the etiologies include metabolic imbalances. Remember the chloride ion and the sodium ion and the potassium ion and how they're involved in the action potential? Those can get off if your kidneys aren't working right, or if you become dehydrated. And when they get off of balance, your brain doesn't work. So just metabolic imbalances, which are due to some other thing not working, can then alter mental functioning and make somebody confused. And they would be referred to as having delirium or an acute confusional state. Adverse drug reactions can do it. Drug or alcohol withdrawal, a high fever. I don't know if you've ever encountered, if you have children, you know, if you have a child who gets up to about 106, they will get quite confused and actually need to be in a hospital at that point. Traumatic brain injury can cause it, and elevated intracranial pressure can cause an acute confusional state. All of these are traumatic brain injury, and all the others are at least somewhat, if not completely, reversible. Probably the least reversible is traumatic head injury. But something like elevated intracranial pressure, if it's corrected and soon enough, there may be no permanent brain injury at all, and their acute confusional state gets better. Or if the metabolic imbalance is corrected, they get better. What are the characteristics of an acute confusional state? Attention deficit, memory and judgment deficits, relatively intact language, and confabulation, meaning making things up. How does that impact an SLP? You will see people who almost look like they have a Wernicke's aphasia, but may actually have an acute confusional state. Or they may have suspected acute confusional state and have a Wernicke's aphasia. Well, wouldn't a CT scan figure that out? Yeah, eventually, but not the first day, because an ischemic stroke leading to a Wernicke's aphasia will not show up on a CT scan the first day. So they'll go digging for other things, you know, involving their electrolytes to search for a source of an acute confusional state versus a Wernicke's aphasia. And they also call the SLP to see if you can determine the difference. And you can. The acute confusional state can manifest like Wernicke's aphasia in a conversation, but once you start testing language versus equivalent non-language performances, they show themselves for what they are. For example, if you determine that a person can carry out one stage, but not two stage spoken commands, point to your right ear and your chin. That's a two-stage spoken command. But they can't do three. They can do two, but not three, okay? So we have some measure of their language comprehension, spoken language comprehension deficit. And then you determine that they can imitate gestures that have three stages. That's an aphasia. If you take somebody who has a breakdown in their ability to follow commands at the two-stage level, they can do two, but not three spoken commands in terms of following them, but they can't imitate that at all. That's a confused patient. They're actually kind of worse at that than just doing it to command, because they kind of don't know what you're really talking about. What are you trying to do here? You want doing this. But if you say touch your right ear and your chin, if their general functioning level is at that level, they can do it, but then they can't do it imitatively. So you see the difference between aphasia versus confusion. It can be discerned very easily at bedside, the difference between those two. All right. Now, last category, cognitive linguistic impairments in traumatic brain injury. We're almost there. The nature of the injury in traumatic brain injury always includes this thing called diffuse axonal injury, or DIA. That is injury at the neuronal and synaptic level. What's it caused by? It's caused by the shearing forces on the brain as a result of sudden deceleration or acceleration. So for example, your head hits the windshield. Your brain is going to decelerate suddenly, and it's going to slap up against the front of the skull, and it's going to bounce around. Pardon me for doing that. It's going to bounce around, and that's going to cause damage literally at the neuronal and synaptic level. It can disconnect synapses. And it's diffuse and bilateral. It's not just at the point of impact. It's all over. Not necessarily evenly all over, but it's all over, and it's bilateral. And that, if you disconnect synapses, obviously there's going to be a problem with cognition. Traumatic brain injury may also include hemorrhages and contusions. Hemorrhages are, you know what hemorrhages are. Blood is leaking from vessels into the brain tissue, and a contusion is a bruise. And those will show up on a CT scan. DIA will not. What happens with DIA is that the initial CT scan is normal. But if you look a month later, the brain is starting to shrink. So the brain gets smaller. How's that indicated? Bigger ventricles and greater space between the brain and the skull. So that it will show up eventually, but not initially. And so somebody can be relatively severely impaired and have only DIA, again, which manifests or which shows a normal CT scan initially. Brain injury can also be complicated and made worse by edema and anoxia. Edema is swelling. Anoxia is deprivation of blood. And those are both complications that are addressed in emergency medicine and must be addressed immediately to try to prevent the additional damage due to those two factors. The effective management of that is one of the reasons why rehab in the last 20 to 30 years has expanded so significantly, because so many more people who would not have survived the initial injury do survive and then go to rehab. Characteristics of the cognitive communication impairments in TBI, they can range from completely unresponsive, completely comatose, and unresponsive even to painful stimuli, all the way up to completely normal or almost normal. Certainly somebody can appear normal in a conversation, and more likely there's something, they have what is referred to as modified independence. They can be independent, even in going back to work, but they need a few little extra use of their calendar and other written mnemonics to help them with their persistent memory deficit. The continuum of functioning for TBI, from extremely severe to very, very mild, is well described on this test that all SLPs know about. It's called the Rancho Los Amigos Cognitive Functioning Scale. The Rancho Los Amigos is a very, very large, I think 3,000 beds, but it's huge. It occupies acres, actually. And it's located in Downey, and they do all kinds of different rehab, but like spinal cord injury and traumatic brain injury, certainly stroke rehab, all kinds of things. But it was developed there in the early 70s and modified in 1997. It's a 10-point rating scale ranging from unresponsive to modified independent. Want to just point out this word rating scale. It's not a test, it's a rating scale. So you just observe, and you can interact with the individual and do some things, but in a non-standardized way, and then finally end up placing them someplace on one of those 10 points. When somebody recovers from traumatic brain injury, their recovery involves moving up step by step on that scale. So somebody could be totally unresponsive to painful stimuli, which puts them at a 1 on the 10-point scale, and end up, when they reach their plateau and don't recover anybody, they're on a 5 or something like that. So they'll tend to move up from 1 to 1 to 1 up that scale. One other, before we look at the scale for a moment, one other thing to be aware of is that concussion is now viewed as a mild form of TBI. And I'm sure you've heard a lot about that in the popular media, you know, the stories about professional football players, et cetera, who really do show the signs of dementia earlier in life, far earlier in life than they ought to, as a result of repeated concussions. And that's been well documented in a number of different studies. And if you're interested in that, it's very accessible information. But we've only really been talking about that for about 10 years or so. Okay, I'm going to click on this link, which you can too. Let me click on my link here for the Rancho Los Amigos Cognitive Functioning Scale, and here it is. All right. So here are the levels. Level 1, no response. Obviously, they need total assistance. And I'm just going to scan through this very quickly. You can look at it in more detail. But a generalized response, which is level 2, means that the person will respond to intensive stimulation, but they'll respond in the same way regardless of where the stimulation occurs. Like if you do it on the one thing I like to do is you just use ice. Neurologists will use painful stimulation, like they'll press real hard on the sternum with their thumb. I'm not real comfortable doing that, and ice is very intensive. So if you put ice, just rub ice on the earlobe. If you see something like looks like this, I rub the ice, they go. And you see, I've raised both shoulders, or I've done something on both sides of the body. And if I do it on the other side, it's the same thing. It's a generalized response. Whereas if you look at somebody who has level 3, they're the localized response. You rub the ice, they go like that. Rub the ice here, they go like that. Within the limits of their motoric ability, they respond differentially, depending where the stimulation is occurring. Level 4 is confused and agitated. They're beginning to show a little bit of language, but there tends to be agitation, can be very pronounced agitation too. Level 5 is confused, inappropriate, non-agitated. Still, they require maximal assistance. Level 6, confused, appropriate. Level 7, automatic, appropriate. They're starting to actually be able to do some certain things like, here it says minimal assistance for daily living skills. What's that mean? It means if you hand them their socks, they can probably put them on. If you hand them their pants, they can put it on. Level 8, purposeful, appropriate. They just require standby assistance. Level 9, purposeful, appropriate, standby assistance on request. That is, they can ask for it if they need it. And level 10, this is the person who is really independent, but they probably do use some mnemonic devices, such as extra use of a calendar or written notes or something like that. But they do that part independently. If you ask them, are you completely normal like you were before the injury? They'd say no. But are they functional? Yes. So that's a very quick, but basically that is your introduction to the Rancho scale, and that's very commonly used by SLPs. In rehab and in our descriptions of the level of performance in somebody who has a TBI. Let me stop sharing that screen and go back to my slides, but I think that was the last slide. Let me just double check that. Okay. See, yeah, there we go to questions. So I'm going to have you work through the questions, and we will leave it there for now, and I'll see you in class. Bye.